So now on to the main event, adherence. It's such a hot topic. Why is it that so many medicines are not taken as prescribed? We're going to hear a bit about what exactly is adherence and then the impact that adherence has on patients and the people who care for them, payers, the NHS, the pharmaceutical industry, and wider society. How it has such a detrimental effect. And one aspect that we will not be able to have time to cover today, but I just wanted to say 30 seconds now, is the environmental aspect. And in fact, we heard it just now, we have medicines which are left in people's cupboards, and what happens to them? How many people actually take them to the pharmacist for safe disposal, or how much ends up in landfill? So if nothing else, if we crack adherence, then we'll actually make the environment a better place as well. We'll be hearing today from Proteus. Very exciting. Proteus is one of the most talked about companies around in life sciences at the moment, and it's an absolute delight to have Proteus with us today to tell us a bit more about what they're up to. And then we'll be hearing back from Hamel on, first of all, the teaser. I'm not going to ask how many in the room have actually answered the questions that I circulated a few days ago. Hopefully a significant number. I understand it was a certain number of you. I certainly found the questions very thought-provoking. So I wonder how adherent you would be. And Hamel are going to challenge a lot of the thinking out there. Why is it that people don't take their medicines? The answers may well surprise you. They'll be looking at some current solutions and also what else can be done. There is a fantastic lineup today, some great speakers on a very important topic. There'll be opportunities for you in the Q&A, as I mentioned, but also, if you'd like to tweet, the hashtag for today's event is PING, P-I-N-G, 2015. So please do join in with your thoughts, and you can follow us also at MABLAW, M-A-B-L-A-W, not MADLAW, as some people may think. So now for our first speaker, Alison Carr of Hamel. Alison is a UK adherence behaviour expert and clinical director at Hamel. An epidemiologist trained in health psychology and medical anthropology, Alison has conducted research into factors influencing adherence to medication, the measurement and management of pain in osteoarthritis, and has delivered patient preference and adherence studies and POM to P switch programs in neurology, urology, and dermatology. Alison is committed to changing behaviour on the basis of robust scientific evidence. Alison will now talk to us about what is adherence. Alison.
Thank you very much, everybody, and thank you for welcoming us so nicely. I'm going to just give a really brief introduction to the rest of the afternoon's talks, just by setting the scene. And you're going to hear a lot of really detailed information about what is adherence and the statistics around it. Sorry, I need to put my glasses on to see what I'm pressing. But I'm just going to start with an overview about what is it and what do we understand by non-adherence. Well, we're going to be talking about a few definitions this afternoon, but essentially what we mean when we're talking about it is that people don't follow the advice or the recommendations for how they how they take their medicines, how they manage their own health conditions. And obviously that has the degree of non-adherence has huge impact on the health environment, on patients themselves, on the people around them. So we're going to be talking about that in a lot more detail, so I won't go into that now. What I'd like to start with, though, is by posing a few patient stories to you, because I think that what the patient stories will do is highlight some of the challenges that we face in understanding and changing adherence, promoting adherence, and illustrate its complexity. So I'm going to start by telling you about a little old lady called Mrs. Jones, who's 82, who has rheumatoid arthritis. So Mrs. Jones was prescribed a disease-modifying anti-rheumatic drug, And she didn't really seem to be making very much progress. And when we went in to try and understand what was going on with Mrs. Jones, her rationale was, well, I'm little. I sat in the chair in the waiting room next to the man who's also got rheumatoid arthritis, and he's twice my size. And so I know that the doctors, they give us kind of standard prescription. And because I'm half his size, I thought, well, probably I only need half the dose. So she had only been taking half her dose of medication, and not surprisingly, therefore hadn't got her disease under control. So that was Mrs. Jones, with what for her was a very rational, well thought out, well reasoned argument for why she wasn't using her medication the way it was recommended. Then we have Mr. Hunter. So Mr. Hunter has gout. I don't know if anyone in the room suffers from gout, but it is said to be more painful than childbirth. I'll believe that when I get gout. But seriously, it is an excruciatingly painful condition that is undertreated, underdiagnosed. And poor old Mr. Hunter did have a diagnosis of gout, had been prescribed medication, allopurinol, by his GP, but wasn't taking the medication. So why wasn't he taking the medication? He was taking it because of all the connotations that, that cartoon that depicts what gout is, that Victorian gentleman with his glass of red wine and his foot up and the big swollen toe. That's still very much in our consciousness as what we associate with gout, and that's just not the reality at all. But he was embarrassed. He was embarrassed about the association that the diagnosis of gout had with the judgments people would make about his about his lifestyle and his self-control. And so he didn't want to go back to the doctor. He didn't want to take the medication. He didn't want to go back to the doctor. So what he did in order to manage his job, which is a long-distance lorry driver, was to fill his welly boots with ice before he went out and did his job. So rather than take his medication or go back to the doctor, he was filling his welly boots with ice. Really desperate situation for him. Have I got another slide?
They're appearing on the laptop.
Perfect. Never mind. My last story was a lady called Mrs. Smith, who's a 56-year-old lady who was prescribed hormone replacement therapy by patches. So she went off very happily. This was going to really help manage her symptoms. Returned to her GP 6 weeks later, saying, I've got a bit of a problem, I don't really understand. The conversation was, how are you getting on with it? How's it managing? She said, well, I don't really understand because I can't actually I haven't managed to use all my treatment. And so the GP was a bit perplexed and said, what do you mean you haven't managed to use it all? And she said, well, I ran out of space to stick the patches on. And I think that, you can't really begin to understand how people can think or behave like this. And they're just 3 examples. I could give you hundreds more from all the different research that we've done of the way that people use their medication or don't use it in the way that it's prescribed. And sometimes it's quite a straightforward matter of not quite understanding, but very often it's much more complex than that. So what I'll spend some more time talking about for my presentation later is what is that all about? How can we understand what drives non-adherence and therefore how to really change it effectively?
Thank you very much, and I meant to say Dr. Alison Carr. So thank you very much for that great introduction. Just sort of whets our appetite about the different sorts of patients that there are.